right? So this is an important topic to me personally. I've worked in admissions in some capacity or another, kind of that front end for over 20 years now. And so it's I've seen a lot of different things in my career so far, and it's really eye-opening when people come in to this level of care. But first of all, I just want to say that I'm thankful and I'm proud to be part of the community of people that you are all a part of as well. Working in mental health and healthcare, we do a lot to serve the people in the community, and it is all about the people that we get a chance to help. We often find ourselves in a really kind of powerful, humbling position where we can really do some good work to influence a pattern in someone's life or help to facilitate some type of change in someone's life to help them along their journey through their mental health process and improvement. So back to what Joseph said a little bit. If you have any questions, if there's anything you want to elaborate on or comment on as we go along, please don't hesitate to share. And because there's a lot of knowledge out there on the other side of this camera that this group could take benefit from as well. So with that, we'll kind of start the slides, but again, if you have questions, please let me know. All right, so just about what we're going to talk about today. Forward. We're going to talk about the levels of care of mental health treatment, specifically the interventions that those provide, and then how we determine what level of care, what is going on in a patient's life that might justify a certain level of care. And then just a little bit of stats real quick. Only about 43%, so less than half of the people that are diagnosed with a mental illness or having a crisis in a year actually seek some type of service. That could be a number of different reasons. It could be, financial. They don't feel like they can afford it. It might be access. It might be availability of their schedule. But there's a lot of people out there that aren't seeking services that really could. Only 64% roughly of adults with a severe mental illness seek services annually. So these are people that may have pretty severe depression, bipolar, thought disorders like schizophrenia, schizoaffective, those type of serious mental illnesses, and they're going untreated about 30 to 40% of those a year. With children, again, it's only about half that need services that actually seek out services. And I'm just throwing this other stat out here. About white populations are 20% more likely to seek services. So I say that to bring up the fact that as we are in the community, we can be a real advocate for people to get into services. So if you accommodate for this 20% more of the white population seeking services, how does that impact the 43% that don't? That may mean that there's significantly less people that aren't white that aren't getting services. So that's the social worker in me coming out, I guess, is that we really can be an advocate for people to get into services and help connect them with services. Again, why that is, I don't know, if it's funding or if it's other people don't feel like there's a therapist that understands their story well enough. It just speaks to us as therapists for advocating and helping promote help for everybody across the board. So in addition to that, why is it important to understand the different levels of care? If the level of care that the patient's needing and the level of care that they're receiving don't match up, it's going to potentially cause some barriers in their progression. It may underserve them, meaning they're not getting intense enough care, or it could potentially overwhelm them. And we'll talk about a little bit this as we go along. But if we're suggesting or implementing services for someone and they can't, they don't have the availability to be present for all of that treatment, then it's not going to work well either for them.
Hey, John, there was a really good comment in chat. Marcia is sharing. She said, I also think that referring to why maybe white populations tend to seek care more often is that in some cultures, there might be stigmas attached to seeking help too. I think that's really important to recognize.
No, and you're absolutely right. Some people may seek the services within their own community. I mean, it may be through a religious leader. It could be that they're accessing services informally through, talking to other family members or rallying around someone else that way. It may be general distrust of a formal mental health center or some type of formal office. So, a lot of different reasons. But again, I think that's why when someone actually does end up in front of us, that we really take them serious. We really try and find out what's going on with them and help connect them with someone that might be able to provide that service for them. Okay, Megan, I'm just going to say, is it my microphone that's echoing or is it somewhere else? Oh, okay.
Maybe someone else. Yeah, maybe just everyone check your microphone, make sure that if you're not speaking, that you keep it on mute, just because sometimes, you might not be talking even, but it might just be like a simple noise of the fan on our computers or something like that that can kind of cause echo and things like that. Thanks.
Right, so the levels that we're going to talk about, and I'll just to name them real quick. First one is just traditional outpatient level of care, IOP, PHP or partial hospitalization, a community integration program / extended care, residential level of care, sub-acute hospital care, acute psychiatric hospital care, and then acute care in a hospital, which typically is, we're talking there about a medical issue. So we'll talk about these as we go on. First off, the outpatient level of care, you could say that there's a level of care just before this one. And that may be, someone that's, reading some self-help books, or they're researching online things they can do, but they actually haven't sought out individual care from someone. It could be that they're seeking it just from a religious leader. But when it escalates enough or situation bears out that they need more, then they may reach out to the outpatient level of care. That's typically like psychotherapy once a week, every other week, maybe once a month. They may have medication management with a psychiatrist. You all probably know it's hard to get in to see a psychiatrist or refer to a psychiatrist. So it may be a primary care physician, a pediatrician, a PA or an APRN that may be working on their medication and help them with that. They may be attending some type of community group therapy, weekly group sessions. But overall, we're asking a patient to commit maybe an hour a week for therapy, and maybe another hour a month or every other month to go see a doctor. So the level of investment at this level is, as far as time and energy goes, is pretty low on the patient's part. So they're still able to fully participate in most everything else that they would be wanting to do: school, work, home life, social life. This level of care really doesn't impact that so much. So what is kind of suggesting that a patient may need this level of care? It may be that the community groups aren't enough. It may be that the AA group or the NA group or whatever group they're going in the community just isn't enough, and they need someone to talk to about what's going on personally. It may be that they've noticed an increase in their drug use. It may be that they're finding themselves to be more irritable or more withdrawn at home. It may be that, a loved one or has pointed out to them, hey, you're struggling here. You're getting really angry real easy. You're getting, set off by the littlest thing that the kids might do. I think you need to talk to someone. So that might kind of be the thing. People in their life are starting to notice what's going on. Maybe that at work too, like, hey, I notice you're kind of coming in late to work a few times a week because there's something going on, or, maybe you need to get some help, that type of thing. And then they refer them, then they probably, most people will, call their insurance company, who can I go see? And then they end up trying to call from a list. But these people, it's important to note that these are people are reasonably safe at home. They're still functioning relatively well to needing a higher level, but they're still safe. They're still functioning, but they've recognized, or those around them have recognized, that there's something else that needs to happen there. So, with this, again, they're able to still function at home, start working with the therapist, start working on whatever, goals they have, and hopefully progress. Next level of care, any questions there now from anyone? That's pretty typical. When people think of therapy, it's usually that outpatient therapy that most people are aware of. Intensive outpatient program, that is a type of program where usually the individual is committing to about 3 or 4 days a week, where they're going to be in services or sessions that usually last 2 to 4 hours at a time. There's a lot of different type of IOP programs, but by definition, it's usually about 6 to 10 hours a week, maybe a little bit more, maybe a little bit less. But it provides real intensive therapy, but it can really vary on what type of services are offered within that IOP. And I bring that up because there's a lot of different IOPs in the community, and some of them have different focus on what they're trying to promote or what they're trying to teach within those programs. Like, for example, we have an adolescent and adult IOP here at Provo Canyon Hospital, and we do also have an IOP that's specific for women here within our IOP, but we don't have what other people have, which is like a substance abuse IOP. So we may cover issues like addiction and compulsion and kind of some self-regulation issues, but we're not the place here if someone wanted to do an IOP focused on addiction. So if you're talking to someone and you want to be sure that they're kind of getting connected with an IOP that does meet their needs. Oftentimes an IOP is focused on kind of a group model where they're doing exercises, they gain insight from each other, there develops a sense of community to hopefully help people progress in the skills that they're learning. It provides a really good opportunity for someone to get treatment, go home and practice what they've learned, and then come back and get reinforcement or extra support on, like, well, how did it go? You tried this skill, or when you've been home, what have you noticed? We've been talking about, different things, different elements, and then, then they get to come back and work on that. IOP schedules, we talk about the level of commitment for the patient. This is more intensive, but it still should allow for the patient to keep going to school, to keep going to work. It shouldn't impact their attendance. There's enough IOPs out there that people can usually find one that's going to work with their schedule. Us here, we have one in the morning and at night for adults. What IOP typically is not, though, it typically doesn't have individual therapy. Like, some do, not all, but oftentimes even that individual therapy within a program gets billed separately as a therapy session. So someone could be doing outpatient therapy outpatient med management in conjunction with the IOP. But that's, if you're working with a client, or it's helpful for them to understand that, because they may think they want to do all of those things, but it might be that they need to take a break from individual therapy, do IOP for a little while, or just do individual therapy, every other week or once a month, just depending on the patient's need. So, IOP can be a really good thing. It's not as invasive in someone's life, so they can still keep moving forward with other things that they want to be doing socially, school-wise, etc. So when would someone go to IOP? This is when, therapy on an outpatient basis just isn't clicking. There just isn't enough reinforcement. The therapist may feel like, we talked a week ago, I gave you some assignments, you come back, you don't even remember what we talked about, let alone, you don't even know what we were talking about last week. How do we start again this week? It's like starting over. Okay, so it looks like there's a question. So are there IOPs that are just individual treatment? Typically not. IOP is usually within a group setting. I'm not aware of any IOPs that are just individual, because they usually have a group component. I think it would be, you could probably find a therapist that would want to do, 3 or 4 hours a day, but that would be kind of hard. Yeah, they receive individual counseling. However, within an IOP setting too, the therapists that are running that, they will be speaking to those people individually, about their goals, about what's going on. But it's not going to be the sit down, tell me about your family structure, tell me about, all those different things that someone might talk to in depth in an individual session. That typically doesn't happen in IOP. But again, so with IOP, again, this is someone that may be struggling at home. There may be some elevated conflicts with parents or within the family, but they're still safe enough to be home. These aren't people that are suicidal. IOP, of course, is not a lockdown type of setting. So people need to be able to come to this type of treatment voluntarily, or at least, willing to be there. Yeah, so those are type of the things where, individual therapy hasn't been enough, and, they may be still struggling more and more at home, and more at school, where it's just, other interventions have not been able to make progress for the patient. Okay, next level up is PHP, or partial hospitalization. Sometimes this is called day treatment. This is a pretty intense level of care. It's similar to IOP, that it's usually group oriented, meaning there's a group of people that are doing this partial hospitalization program. They're going somewhere and they're participating in group activities. But with partial, there's usually included that individual therapy piece. There is also usually med consultation that happens within a partial hospitalization setting. This is a level of care that someone is, and let me go back to IOP a little bit. IOP usually runs about 60 to 90 days, depending on the program. Yeah, okay. Tracy, I'm just reading that here. It says, generally, there are program requirements to include the full program. I'm unaware of just groups. Are you talking about the IOP or the partial? If you want to unmute yourself for a second, please.
I was answering the question from, who was above me? From JC.
JC had a question. Are there group therapy options where people just come to groups? It depends on the IOP program and how they've built that.
our program, people are just coming to the groups. We don't have an individual therapy component attached to our program, or a med management piece. So if someone was to do that, they usually have to find it on the side. Yeah. Okay. Let's see. Daniel has a quote there. Yeah. Yeah, and that's a good point. A good thing about PHP level of care is it's usually the last stop before stepping up to, could be a last stop before stepping into acute care. It's a really good step down tool from going from acute care into PHP, because it is so intensive, that provides a lot of structure and really helps for some good stabilization. It can provide for some good support for whoever that patient's support system is outside of the home. Not that it's daycare, but if my child's in PHP, then I know that they're somewhere they can be safe and watched, during the day and getting treatment, and that I have, someone to follow up with the next day if I need to. With the psychiatrist in PHP, it's usually not every day. To see a doctor every day, that's usually having to be in the hospital. But a doctor may be available as needed. If Johnny was seen last week and he's had his medication and it's something needs to be changed, then that can probably be looked at faster than trying to make another outpatient appointment. So the doctor is usually a pretty inclusive part of the partial programs. So other thing with PHP to notice is that, or to note is that oftentimes if it's an adolescent, they have a school component. So the kid would withdraw from their current school and enroll within the school program. So they still get credit for school. And then when the kid's leaving from the partial program back to regular school, they may have an IEP that was started or in place, so it provides for a better transition back to the community.
Hey, John, there was a really good question that came in here regarding PHP. Victoria's asking, does the medication have to be managed by staff?
Meaning like the handing out of the medication?
I'm guessing that's what she's asking. Yeah.
Okay. Typically, while the patient's at the PHP, the nurse there would be handing out the medications if they're supposed to have any medications, while they're in treatment. Don't really want kids, or even if it's not kids, with pockets full of medication. We don't want them, trading medication or taking them when they're not supposed to. So typically within a partial, the medication is dispensed by the professionals there at the partial program. So, okay, so when does someone need partial hospitalization of care? This is when someone hasn't been able to function very well at all at home, or maybe work, school, and they need to have that treatment pretty intensive. And again, it's not daycare, but it's providing ongoing treatment and support that then can be reinforced at home and then come back the next day and reevaluated. Interventions happen, then go back home, work on it. It really helps people to kind of re-enter into their regular communities, but not being fully discharged into whatever systems they were maybe before they were in the hospital. So that's why it really works well for a step down. But these are people that can be, again, big part here is that they can be safely managed at home, that they're not suicidal. Doesn't mean that they might not have suicidal thoughts, but they're deemed safe enough where they can, safety plan with their families or whomever when they're home. And there's a good understanding what to do if that escalates. And that's something that they may be talking about in treatment. This is a level where there are probably a fair amount of people that have somewhat chronic suicidal ideation or self-harm ideation. But it gives them an opportunity to process that and get a better understanding of that. Again, when it talks about a more intensive medical supervision, that again is the access to the doctors more frequently, access to nurses more frequently, to see what's going on. So if there's some type of, I'm not a doctor or nurse, so full disclosure there, but if someone's having some type of complication with their medication, then it gives them access to someone that can look at that quickly. Okay. Oh, Kevin, you want to go back and do you have a question? If you want to unmute yourself.
I just wanted to catch the part about the evaluation by psychiatrist, but you kind of answered it in the other slide, so I appreciate that.
Okay. All right, so the next level of care somewhat provides kind of a break in what's typically available to the populace. Outpatient, IOP, partial hospitalizations, those are all general things that commercial insurances will cover. Or it may be things that are part of the mental health centers of the community, or that are run by the counties or whatnot, depending on what county you're in, I guess. But this level here, community integration or extended care programs, these are typically patients that are publicly funded, meaning they have Medicaid or they're on disability, they may be on civil commitment, and they're usually operated by the mental health center. So in our area here, that would be Wasatch, that kind of provides some of these trainings. So this is where the patients has somewhere to go for therapy, somewhere to go for medication. They may be involved in some type of clubhouse setting, in the sense that if they're having a bad day or they're having to come in for check-ins several times a week. It may be that they have a caseworker that's helping them with getting housing, or making sure that they're filling out their medication or their Medicaid forms that they need to do, or just kind of helping in that day-to-day living. Case manager may also be helping coordinate with different care providers. If there's a medical need that patient has, they're helping make sure that they get an appointment set, or they get to an appointment, and that there's coordination between the different levels of service. So this is for someone that maybe has demonstrated a real chronic need for mental health intervention, that hasn't been able to maintain with those other levels of care that we provided, or that we discussed just a little bit ago. So sorry, the mouse is being really fast here. So again, this would be a hard referral to make for someone to go into this level of care. Someone that's in this level of care has probably gone up and down this ladder, so to speak, a couple of times before this type of level of care is provided. Because again, they're going to have to likely be within some type of state or county program that provides these services for them, because your Blue Cross or your Select Healths of the world aren't going to likely cover anything like this. Next level here, this is residential level of care. So again, as we're progressing through this, we've been talking about someone's ability to function within their home setting, where they're still able to participate with their family, their friend group, social group, whatever that may be, their employment, their own choice of recreational activities. As we kind of progress through the levels of care here, that freedom, if you will, or that availability of time to do what they want to do becomes more and more restricted by their treatment that they're needing. residential care is a pretty big step up on that. This is where someone is going to go and live typically no less than 30 days when they're going into a residential type setting. Depending on what it is, it could be 60 days, 90 days, a year or more, just depending on what the need is. Patients that are at a residential facility, they're living there. They may or may not be granted home visits, just depending on how they're progressing. They may be out of state. Their family may be, I know we have a lot of residential treatments here in Utah, right? So a lot of times these kids come from California or Alaska, they come from all over the place to be in treatment. And so, home contact is pretty limited. Residential centers for adolescents, they are required to have a school component. They are required to do, provide that education for the kid. It's not the same type of education, if you will, as someone was in a basic, school that wasn't also residential treatment, but the kids should be getting class time and IEPs and all those different types of things while they're in a residential setting. Oftentimes, if the kid's being referred from out of state, it could be, I know in Utah, we get a lot of kids from California that are referred by their school districts, actually. And so the residential centers have to provide an IEP or follow an IEP guidelines as part of a treatment plan. So it's pretty intensive that way. While they're in that setting, it's all of their services are generally provided for in there. They're having their individual therapy, group therapy, family therapy is happening. Their medications are being managed by whoever that provider is. General medical care is provided. Pediatrician or family practice doctors often come in to see patients there or round on patients. And it's one thing to consider is that a residential treatment center is kind of a community within a bubble, if you will. And the facility brings providers from the community into that bubble to meet the kids' needs, as opposed to taking them out. Now, if there's a specialist or an emergency room type of thing, they may take them out of the facility to go get that care. But basically, they're going to have them within that bubble and keep it in there. There's different levels of residential setting. When I say levels, I mean as far as the security. Some might be set up more like a group home, where it could just be a house in some neighborhood. I know those exist, and it's not, there's not a barbed wire fence around it or something like that, but it is typically more secure. I mean, there's staff there 24/7, all the way up to, you may have some residential facilities that are pretty locked down. They're more therapeutic focused, but they're pretty secure. I mean, you'd see the walls around the building and whatnot. So, if you're looking at referring someone to a residential level of care and you're talking to a family, you would want them to do their shopping just as the same as any of these other levels of care, to make sure what's going on in that facility as far as what level of acuity patients do they treat, and is that a good match for the individual that might be referred. Speaking to residential care in our community here in Utah, lots of facilities for kids. Residential care for adults is almost nil. I mean, there's very, very little outside of rehab, substance abuse. There's not a lot of residential care for mental health. So going on here, what type of criteria would someone need to be meeting to need residential level care? This is, again, where it's pretty severe, not able to function socially in school, home, those major type of arenas within their life, if you will. The patterns of behavior are usually along the lines of kind of oppositional, defiant type of behaviors, conduct disorders. Residential care is more for, maybe the kid that's running away, that's getting in trouble, is lying to parents, they're, sending pictures they shouldn't be sending to people that shouldn't be getting them, and they're putting themselves in a vulnerable situation. Residential is probably the better place for them to be, where they can be in a safe place and have those behaviors addressed. And again, the big thing is, if someone has tried IOP, they've tried partial, and they're not progressing, then they maybe need to go into a residential level of care. So the question there on the residential care, there are some for children, those are a little bit harder to come by too. Generally for residential care, we're looking at kind of a 12 to 18-year-old population. Some residential centers do have a transitional type care track where they may be from 18 to 21, where they could still be within that. But those are typically for people that have kind of graduated from, they were in residential at age 18, and then maybe they need to transition further. They need some further support. Sometimes residential is an alternative to, I put down there, criminal incarceration, but it could be that, you either go get treatment or you're going to end up in juvenile detention somehow. But again, this is, providing a secure place to help them get treatment, to help modify those behaviors, to help them gain better insight. They can still get the medication management while they're there. But for those behaviors to change and for someone to develop more insight into those, if they're not able to do it at home because they're not safe, this is where residential comes in, because they can provide that ongoing therapeutic environment, therapeutic intervention for both the kids and hopefully the family, as well as the families away from the kid. Hopefully they're learning some skills too, until it's at a point where the kid's safe to go back home and function within that family setting or within that community that they might return to. So the next level up, and we'll talk about this a little bit, but residential care and acute hospital care, they have some similarities, but they do have some real differences. So acute care, it's one of the main services that we provide here. But the goal here is not a long-term type of setting. A typical admission to the hospital is about 5 to 10 days, maybe a little bit longer. It would be really rare for someone to spend less than 3 days in the hospital. Not that doesn't happen here or other places, but it would be pretty exceptional that someone left before 3 days. Typically when someone's admitted to the hospital, day one is we're just trying to get to know you. Day two, a medical doctor is doing a history and physical. The psychiatrist is seeing you for the first time. Day three, there's a treatment plan that's been formed. So again, those first 2-3 days in the hospital are just, where the hospital gets to know the patient so they can, really start that treatment effectively. And then for the next 5 to 10 days, working through that treatment plan or helping to stabilize that individual so that they can return to a lower level of care. Within a hospital setting, there is group therapies that go on. There's different types of group therapies. Some run by nurses, some run by therapists, some run by recreation therapists. Just depending on what the facility has to offer as far as space will kind of determine what activities they have. Important to note here that in an acute hospital setting, there is not a lot of individual therapy that happens. The individual therapist does meet with them, but it's not the intensive, you're going to have therapy session every day. Hospitalization is, again, more about stabilization and helping return them back to a lower level of care. And there's a whole team that works with an individual while they're in the hospital. There's dietitians and therapists, nurses, the doctors or the PAs. There's a whole, discharge planners that are working with the individual, and also should be working with, to some degree, the system that they're going back to, if it's their family or if they're going from here back to one of those other lower levels of care, then we want to coordinate with whoever that may be to help it happen. Typically in a hospital setting, there's a family session or some type of session with whoever is going to be, receiving that patient after they leave the hospital. And there's likely, it may not be like always a real formal session, because there typically is communication that goes on throughout the stay of the hospital. Sometimes that ability to communicate with people outside of the hospital is limited by the patient, because they don't always want that communication to happen. So it's one thing we have to work through. So what would indicate for a referral to an acute psychiatric level of care? The big one that you probably all know about is danger to self or others. I know we hear that a lot, where they're engaging in life-threatening, destructive behavior or disabling to self, but this is out of a psychiatric illness. So this is where I kind of reference back to, the residential level of care. If a kid's not coming home at night, or they're real defiant with parents, they are a danger to themselves, because they're putting themselves in compromising situations, but a hospital doesn't really provide that much of intervention to address that issue as a residential may be. If the kid is suicidal, then that's maybe another thing. Now, it's not to say that people don't get admitted because of dangerous situations that they put themselves into, but it's just, where is the most benefit going to be for the patient? If we have someone here in the hospital for a week, 10 days, when they're released back home, there's been a medication adjustment, maybe there's been some connection to help the patient, see a therapist, but the resolution of whatever conflicts there were, or the antecedents to all that type of behavior, really wouldn't be fully addressed while being in the hospital. So just need to kind of clarify that piece there. And part of what we're looking at here is the symptoms that are going on. They need to rise to the level of 24-hour modification or monitoring, excuse me. So, these are things like, psychosis, severe depression, self-mutilation, self-harm, hallucinating, or just generally the inability to care for self because of a psychiatric illness. So it may be that you have someone that may not be suicidal, but they are so depressed that they are not getting out of bed. They are not able to go to work. They are not able to take care of their kids. That does rise, in my opinion, that does rise to the level of needing hospitalization, because they've not been able to access those services at a lower level because of the state that they're in. So in my experience, we don't have much difficulty getting authorization from an insurance company for someone to be treated inpatient if we can demonstrate that that person is just not functioning at home. So that's part of that there. Also, if someone's psychiatric illness is impairing their ability to address their own medical issues, then they may be admitted to the hospital for that as well. You may have someone that's going through a psychotic episode, and because of that, and because of their paranoia, they're not checking their blood sugars, or they're not dosing themselves correctly with whatever other medications they might have for medical issues. So you need to get that psychiatric piece taken care of, so they're able to take care of themselves like they were when they were more stable. Also, if someone needs to come into the hospital for a medical detox, oftentimes those detox units are within a psychiatric hospital. We have a detox program here. Not every inpatient acute psychiatric unit does detox, but the conditions for a detox admission means that they need to have some level of need for medical intervention. So most insurances won't cover detoxes for substances like methamphetamines. Hospitals generally won't cover detox for that. If someone wanted to stop using marijuana, they're really not going to cover any type of medical detox for that. Cocaine. Typically, the only things that insurances will cover are alcohol, benzodiazepines, and usually opiates. Some insurances are a little bit slower to authorize for opiate detox. They will say that there's no medical need for it. You're not going to be at risk for death for coming off of opiates, but the counterpoint to that, where we are able to kind of get authorization, is that the physical symptoms that come from withdrawal from opiates rise to a level where they can't be managed outside of a hospital. And those symptoms, if left untreated, is going to cause the patient to relapse or reuse. And so detoxing on an inpatient basis, where they can get the medication and the monitoring they need, can get them to a point where they're at least sober for them at the time of discharge, where outpatient or residential level of care for substance abuse can be more effective, because people need to have that separation. Again, I talked about this before, but kind of a severe deterioration of level of functioning. If someone's not able to function at all at home or attend to their basic responsibilities, then they may need hospitalization. An acute behavioral control needed. This would be like acute behavior that's, again, coming out of a psychiatric illness. Sorry, go back to that real quick. It could be like delusional behavior, where someone's stockpiling whatever that they don't need, or they're going door to door and they're telling people that the aliens are coming, or the government is in your TV, or whatever else it may be. Or it might be that they're really agitated in public. It may be the person that's come into the store yelling and screaming because of some type of psychotic phenomena. But that type of behavior, that type of psychotic behavior that needs to be managed in a hospital setting. So, and that type of behavior is different than antisocial behaviors, or things of that like. Acute care, medical care, hospital intervention. That's the one that kind of trumps everything. This has to be addressed first. So if there is someone that has attempted to harm themselves, maybe they have overdosed, or maybe they have cut on themselves, they need to be seen at a medical hospital first. It may be a very legitimate suicide attempt, and they're going to need psychiatric care eventually, but we need to make sure that they're medically stable before they could come here, or really to any psychiatric unit, to make sure that they're safe. So different things will will require some type of medical intervention before psychiatric intervention happens, to help determine what the level of care should be. I know oftentimes, well, a lot of times we get a lot of patients from emergency rooms. And sometimes people call here and they say that they would like to come in, but we have to refer them to the emergency room first to make sure that they're stable enough to get here. For example, if someone's experiencing some type of psychosis, that could be their mental illness. It could be something else biological or medical. It could be influences of, different drugs, alcohol, all kinds of different things. So we, here, and really for any inpatient acute psychiatric setting, we need to do the rule out for those medical things so that we know that this is the appropriate level of care. Psychiatric units like ours, like maybe Highland Ridge or Salt Lake Behavioral that are freestanding, we don't have the access to all the medical services here that, maybe another inpatient unit may have that's housed within a medical hospital. But again, the important piece here about, considering someone going to the ER or just coming directly here is that the person needs to make sure that they're medically stable enough for this level of care. All right, so we're going to go, so again, we went through these just real quick. Someone needs to go to an ER or a medical hospital, if there's suspected overdose, if there's self-harm that's going on, altered level of consciousness. Sometimes if someone's had some type of chronic advanced disease, such as, liver disease, kidney disease, respiratory disease, especially if they're detoxing, we want to make sure that they're medically stable to come to an acute level of care. We just want to make sure we here and done work in a lot of emergency rooms over the years. And, when you're looking to admit someone psychiatrically, everyone really wants to make sure that someone is stable enough, for that acute level. This is, you can read this when we send it out. I know we're getting short on time.
And let me just interrupt really quick, John. So for anyone who needs to go and cannot spend any more time with us today, I've posted the evaluation link in the chat. If you, for some reason, cannot access that, please send me an email and I will send that to you directly. The code that you'll need is levels 118. So levels 118, that is the code that you'll need when you enter the evaluation.
Okay, and just real quick, these are just some basic tools. This is a tool that's put out by Aetna, the insurance company. So you could download this, and so that way, you can look through that, and it will help you score a patient to see what level they may need. This is the ASAM criteria as far as looking for detox. Whether or not a patient needs that, you can look at that here. This is another tool that you could work with a patient on that helps, identify adolescent and child risk and what the level of care may need to be for an individual. No questions, we've gone through that. So this is pretty fast and furious. Again, this is a big spectrum of treatment. There's a lot of nuance to it. So, if you have a client that you're working with and you're kind of wondering what might be the right level of care, you can look at those kind of self-scoring things that I showed just there at the end. Here at Provo Canyon, you're welcome to call one of us here in the intake department, and we can kind of staff a case with you to see if it's someone that needs help. Someone, we can have people come in to the hospital here, and we do offer a free level of care assessment to see if they need to be inpatient or if they need to maybe be referred to another type of program. It's the same kind of assessment that happens in the ER, but it's not as time consuming. But again, I say that, with the caveat that if there's one of those things that suggests they need to go to an ER first, then that's where they should go. And then that evaluation can happen there too. And then we may be able to take the patient from there. But again, if people that you're working with, you want to give us a call here, we can talk about it. If you want to give our number here for admissions, and I'm happy to talk to whoever about, whether or not, certain person's loved one or themselves may need admission. Happy to talk to about that. Happy to have them come in. We do that here. ER does that same level. Other freestanding psychiatric hospitals provide that same level too, where they can go be seen. But it's a difficult thing for some people when they're in crisis, because they don't always know, well, what do I do now? Because it's not something that happens every day in their lives. So again, happy to talk to anybody that you maybe need to refer, or if you want to talk yourself to one of us here and staff a case, we're happy to do that too. Any questions, anything else I can try and answer in the last couple minutes here? Okay. Well, thank you. And then again, I'm happy to talk to anybody whenever, if you have questions or about accessing services here or elsewhere, happy to do that. So thank you everyone for coming.
Thank you, John. Yeah, if there are no questions, we'll go ahead and get the certificates sent out. Give me a couple days for for everyone to be able to answer the questions on the evaluation, and then I'll send out the certificates hopefully by Friday, if everyone's had a chance to answer those. And again, if you have any questions that come up later, shoot those to us. We'll direct them to John or whoever needs to answer those. And thanks for coming, everyone. This has been a really great presentation. I think it was very informative. Thank you, John, for the time and preparation you put into this presentation today. And I'll post the evaluation one more time, just in case anyone needs it.